A very good afternoon to all of you. On behalf of the College of Physicians Malaysia, I would like to welcome everyone to today's webinar. This is our month of infectious disease. And this week, our very first topic, would be HIV-associated cytopenia and malignancy. And to enlighten us on this topic today, we have with us our speaker, Dr. Ang Peng Peng, consultant ID physician from Hospital Seberang Jaya, and our chairperson for today, Datuk Dr. Chow Ting Soo, consultant ID physician from Penang General Hospital. Over to you, Datuk Chow.
Thank you, Norisha. Welcome and good afternoon to all the participants. And this is a little bit welcome to me, as it is away from what we always dealing with for the past 2 years of COVID. So this topic is something away from COVID, and which I almost welcome this as a change. And with me today, this is the first series of infectious disease CME touching on HIV. And with me today is Dr. Ang Peng Peng. She is the consultant infectious disease physician in Hospital Seberang Jaya. And she is actually handling the infectious disease unit in Hospital Seberang Jaya together with Dr. Cheng also as well. And she has a very good experience in handling cases of HIV with cytopenias also as well. That's why she's actually chosen to give this topic. And without further delay, I will like to pass the platform to Dr. Ang Peng Peng. And as usual, please welcome Ang Peng Peng.
Thank you so much, Dr. Chow and Dr. Norisa, for inviting me for this, giving this topic. Please don't believe in Dr. Chow. She want me to talk in this topic simply because I have a good friend who is a hematologist. Yeah, so she said I'm the best person. All right, so without further delay, I would like to go straight to my slide. Yeah, before we start, I think we have to know what is the definition of cytopenia. So cytopenia can be either affected single cell line, isolated cell line like white cell count, HB, or platelet itself. And we know anemia, thrombocytopenia, or neutropenia if it's only affect your neutrophils, lymphopenia if it's only affect your lymphocytes. When that affecting 2 cell line, then we call it bicytopenia, and affecting 3 cell line, we call it pancytopenia. So I think all of us are very familiar with the definition and the number that I put out. I'm not going to go through this one by one. Why is this topic appear to be so important, HIV associated with cytopenia? I managed to find a few papers that published a few years back. If you look at the first author Choi et al. In 2011, when they're looking into the prevalence of a cytopenia among HIV treatment naive patients, meaning that HIV patients that are not treating with antiretroviral yet, the percentage, the prevalence is actually not uncommon. If you could see here, almost 26% of HIV treatment naive patients presented with 26% of them present with lymphopenia, 10% neutropenia. And another author, Fern Harbour et al. In 2010, similar populations, he found that 14% of the patients presented with neutropenia, 12% with anemia. Subsequently, if you look at Ken Yung et al. In 2019, the prevalence that he's seen are actually higher than those previous author, whereby 65% of HIV treatment naive patients are associated with any one form of cytopenia. So this percentage tells us that actually prevalence of cytopenia among HIV patients are actually quite high. And this Ken Yung et al., they actually look into a risk factor that associated with cytopenia, and they found that being female with HIV, CD4 count ranging 50 to 200, and underweight are statistically associated with cytopenia. Then you look at this, another author, Gabriel et al., just published 2 years ago. This is interesting because just now we were looking at the population which with treatment naive. How about those already on treatment? If you look at this cohort of patients, majority of them, 90% is already on ART more than 1 year. 86% of them, CD4 is already more than 200. In other words, that all these HIV cohort, they are already well treated. Despite they are being well treated with antiretrovirus therapy, 40% of them will still have at least one form of cytopenia. Right. And this Lina Fan et al., what did she found? She found that actually this cytopenia could be reversed after about 2 years of getting treatment of ART, but only 70% of them will recover from cytopenia. So I'm just trying to tell you that the prevalence of cytopenia among HIV patients, whether on treatment or without ART, are actually not uncommon. Although we know it's reversible, but looks like 25 to 30% of them, even we treated with good CD4, they will still remain cytopenia for the rest of their life. All right. So again, we need to know this topic because it's common. And we know that any form of cytopenia in any patient is always associated with high morbidity and mortality. And we need to know because this is treatable and reversible. And of course, this is preventable. So how do we prevent? Is we prevent HIV from occurring in any of our people around us, isn't it? So before I start into the approach, let us look at 2 cases. This is Mr. M.I., a 30-year-old male. He was actually diagnosed to have retroviral disease in year 2020 when he presented with cryptococcal meningitis. And after treated him with then we started him with Pembrol EM efavirenz. For your information, this is our first-line antiretroviral therapy. Yeah, but very sadly, this patient didn't take his medicine properly, and he is obviously not compliant. 6 months after the antiretroviral therapy, his HIV viral load was still very high, and the CD4 are dropping down to only 23. Then subsequently, he decided to default. So last month, he actually came back to us, presented with 2 weeks history of fever and diarrhea. Otherwise, he claimed he still could tolerate orally. There is no symptoms to suggest a possible OI like a pulmonary OI or central nervous system OI. If you look at the temperature chart, it's true enough, he having fever and diarrhea about 5-6 episodes per day. So this is his count. Because today's topic is about cytopenia, so I don't want to bore you all with all kinds of investigation results. So I just go straight forward. His total white on admission is 0.9, HB 10.5, platelet is 133,000. So this is a pancytopenia with a HIV patient. So after we counsel him because of the fever, we really suspect of opportunistic infection. So we managed to perform bone marrow on him. And apparently he responsive to IV tazocin that we gave to him. And the blood culture came back, say this is Acinetobacter species, which respond to the antibiotic that we were given to him. So he looks well afterwards, and we actually discharged him. And we converted to oral Augmentin and let him go home. So, but we know that life is not always that straightforward, isn't it? Yeah. So after a few days, he was discharged home, but this result returned back to my ward. And the bone marrow biopsy that we performed shows that extensive tuberculosis infection. So we actually call him back and start treatment for him. So this is a good example of a HIV with a cytopenia, not on effective antiretroviral therapy, come back with an opportunistic infection. Then let's look at second case, 63-year-old Mr. Lim. This patient have a retroviral disease since 2006. If you look at this patient, are totally different from the first case. He is a good boy, that he complies to our treatment, never miss his follow-up, never miss his medicine, and is doing perfectly well ever since 2006. But unfortunately, if you look at the chart at the right side, every year you could see that his hemoglobin are actually dropping. But however, he remained asymptomatic. There is no bleeding tendency to explain for that. And he also denied to have any symptom to suggest of peptic ulcer disease. We all know a clinician who used to treat HIV patient, we know that this is microcytic anemia. So quickly we know this should be associated with our antiretroviral therapy, which is this Combivil, which contain zidovudine. So we switch his antiretrovirus to Transfusion EM and continue his efavirenz. After since then, his HB actually slowly pick up, and the latest HB was 11. Yeah, so these two case scenario is just want to illustrate to you that we are seeing different cohort of HIV patient with treatment, without treatment, and we are seeing different kind of cytopenia and different reason for them to being cytopenic. So now, HIV-associated cytopenia, isolated single cell line involvement, bicytopenia, pancytopenia, is either of them, could be due to infection, yeah, and could be due to malignancy or hematological malignancy, or due to hepatitis co-infections like hepatitis B or hepatitis C, nutrients deficiency, due to a medication, whether it's antiretrovirus therapy or something else, like supplements or traditional medicine, or it could be due to autoimmune related. But again, life is not always simple. When a HIV patient come to us with a cytopenia, it's not that straightforward. This is due to infection and that is due to medication. A lot of time, all of these risk factor and these causes are actually interrelated. Yeah. For example, a patient with a HIV come in with an opportunistic infection. A lot of time, this opportunistic infection can actually activate the immune cascade and causing cytokine release syndrome, causing HLH disease. And infection also could cause a malnutrition because patients don't feel like eating, loss of appetite, or some patients have a GI-OI, enterocolitis, and they keep on having diarrhea with malabsorption, so they will have nutrition deficiency. Then, of course, to treat their opportunistic infection, a lot of time we are using high-fi antibiotic, we are using antifungal, antiviral antibiotic. So all those medication could associated with cytopenia, and as well as the antiretrovirus therapy. Then after that, we also know that a certain hematological condition like Burkitt's lymphoma are highly associated with HIV disease. So all these hematologic disease, when they present to the hematologist, they could actually present it like IHA, TTP, HLH disease. Yeah, and similar when they have this malignancy, patients tend to have a loss of appetite, and they could have a GI side effect of the treatment itself. Yeah, so this is a few examples trying to tell you that all of them are actually related to each other. So when we do see a HIV patient coming with cytopenia, actually not that straightforward, right? So I going through a little bit more details about these causes of HIV associated with cytopenia. As what I mentioned just now, infection is one of the common cause of HIV-associated cytopenia. It's through the mechanism either by destruction of the blood cells, the infection itself causing destruction, cytotoxic to the blood cell, or because of marrow infiltration causing a production issue or consumption issue like activate a DIVC cascade, or a medication we use to treat infection itself can cause cytopenia. Yeah. So when we talk about infection in HIV, basically we are talking about virus infection, bacterial infection, fungal parasite, usually opportunistic infection, and atypical bacterial infection. So the infection in HIV patient could have related to HIV or non-related to HIV. So for example, HIV infection itself also could cause a cytopenia. Then HIV causing a patient being immunocompromised and T cell depleted. So they tend to have all these CMV, EBV infection. Then non-HIV related would be our dengue infection, COVID-19 infection, which also associated with cytopenia. HIV patient could come in with any form of bacterial infection. Yeah, so salmonellosis is particularly common, especially when their CD4 is less than 200. Yeah, it's just an example. Then opportunistic infection, because their CD4 is less than 200 by fungal or parasite. The commonest one will be our PJP, our histoplasmosis, penicillosis, and a non-HIV related one could be malaria infection. Then mycobacterium infection are very common in Malaysia, TB or a non-tuberculous mycobacterium infection. So in another way, HIV patient can actually infected by all kind of organism. Okay, either it's HIV related or not HIV related, and majority of them could associated with cytopenia. So how about malignancy? Actually, I mentioned just now, like things like hematological malignancy. Some HIV patients, they first presented to hematologists when they have their bone marrow or peripheral blood film that's suggestive of Burkitt's lymphoma or plasmablastic lymphoma. So the first thing, if hematologists saw this diagnosis, the first thing they do are actually HIV testing, because it's so highly associated with HIV. Yeah, so Kaposi sarcoma, we are seeing not so common nowadays because of early detection and early treatment. Yeah, but Kaposi sarcoma is also associated with HIV and causing cytopenia. Then some HIV patient could have a non-HIV related solid tumor or solid malignancy. Yeah, but a lot of time we still believe that all these cancer, when they occur in HIV patient, are actually due to immune dysregulations. Yeah, so having a HIV, although patient get a treatment earlier and they never have opportunistic infection, but we still believe that they have some form of immune dysregulation, and that is the reason they tend to have a malignancy, and particularly true for hematological malignancy. Hepatitis co-infection, I think all of us know very well. When we have a Hep B, Hep C with a cirrhosis, and then some patient will go into portal hypertension and liver failure. And when you do have a portal hypertension or liver failure, of course you have low platelets and you have varicose bleed, then you will have anemia, and a lot of them have hypersplenism and further worsen the platelet count. Then autoimmune related, so it could be directly related to HIV itself, or it can be through infection, opportunistic infection, or it can actually through the malignancy. So it can be de novo, that due to immune dysregulation that associated with HIV, or because of HIV causing OI and then activate the immune system, or HIV associated with malignancy that activate the immune system. Yeah, so it could cause autoimmune destruction, and very well known is our HLH disease. Yeah, and HLH could present without OI, without a lymphoma or leukemia, just because of HIV itself, or is with OI. All right. Then a medication that we use to treat HIV patients when they presented with opportunistic infection, or some of our HIV patients themselves believe in traditional medicine and bone medicine. So they tend to take some supplement or traditional medicine that cause cytopenia. So history taking and a full details of medication history are often very important when we're dealing with HIV-associated cytopenia. So these are the list of commonest medication that we use in HIV patient that associated with cytopenia. Then nutrients deficiency that I explained just now, due to loss of appetite or due to a complication because of a stroke, because of hydrocephalus, because of enterocolitis. All right. So after going through the multiple causes of HIV-associated cytopenia, I'm not sure actually I'm confusing you all and making you all more worried that so confusing. Yeah, so don't worry. I'm going to show you how should we properly approach HIV population when they presented to us with cytopenia, right? The approach of a HIV patient who come in with a cytopenia not only can guide us to get a diagnosis for our HIV patient, also there is a clue for us which type of patient or HIV patient we should empirically start antimicrobials. When I say antimicrobials, it is anti-TB, antibiotic, antifungal, antiviral. It's not only antibiotic, okay? And then what is the indication to transfuse platelet, to transfuse PEG cell in this kind of patients? And is there any role of this new pollutants, especially when we're dealing with neutropenia HIV patients? And how about timing of antiretrovirus initiation? So if you do have a HIV patient come in with a cytopenia, if you want to know what is the subsequent approach, a very easy way is you differentiate them into these two big groups. You differentiate them into either they belongs to a normal CD4 count. Normal CD4 count means that CD4 counts more than 200 cells per for ultraliter, and low CD4 counts means your CD4 count less than 200. But you all know that to wait for your CD4 count result to come back, the earliest could be 2 weeks or some even longer, isn't it? So if I want you to wait for 2 weeks, sometimes it's not really practical. So there are a little bit, there are some of the clinical clues that we HIV treaters are used to use to guess what kind of CD4 counts that our patient has. Yeah. So if your patient, HIV patient come in with cytopenia and your patient already on effective antiretroviral therapy more than 6 months, we can group this patient likelihood they belongs to a normal CD4 count cohort. All right. If your patient have an oral thrush, most likely is low CD4 count. And your patient do have constitutional symptoms like loss of appetite, loss of weight, and looks very cachextic, of course they belongs to the low CD4 count group. And appearance, if they still looks very handsome, their skin looks still very shiny, then they belongs to the normal CD4 group. If their hair looks like losing and then alopecia, their skin are very dry with a lot of scratching marks around and not so handsome looking, not so beautiful looking, then they are actually belongs to a low CD4 count. Then a nutritional status, like whether they present of ulcers, you know, and they look very cachextic, as I mentioned just now, then it belongs to low CD4 count. Another way that are very good is looking at the absolute lymphocyte count. Absolute lymphocyte count that less than 1.2 actually is a good predictor for a CD4 count of less than 200. Okay. Yeah, this idea coming from a few researchers, because in some of the country, resource limited country, they are not afford to perform CD4 count. So they are looking into a simplest and cheapest way to have a predictor of CD4, and they look into this absolute lymphocyte count. All right. So after you decide that your patient belongs to the low CD4 count, then you further divide them into whether they are clinically stable or clinically not stable, meaning they have a hemodynamically compromised. Either they are symptomatic or they are not symptomatic. All right. So this is very important. If when your patient come in with low CD4 count and they do have symptom and hemodynamically not stable, while waiting for a thorough investigation and a result to turn back, of a lot of the time, we need to decide on empirical antimicrobial initiation, and this could actually save their life. Sometimes, based on our experience, we have to decide antibiotic alone or combination antibiotic with antifungal, or even antibiotic, antifungal, and antiviral. Yeah. So, but even your patient you think is less than 2, CD4 is low, but your patient relatively stable without symptom, then we have more time. We can allow a week or 2 for our result to come back, and then we treat accordingly. When you have a patient come back with low CD4 count in HIV patient, most likely majority of the time you are dealing with opportunistic infection or hematological malignancy. Okay. Usually these are the 2 main things you are dealing with. Yeah. After after go through a thorough physical examination and investigation, when the result come back and true enough, we treat targeted treatment started, then we have to quickly think of initiation of antiretrovirus to prevent a further opportunistic infection. So how do we guess that what kind of opportunistic infection we are dealing with? So there are a few methods that we can use. CD4 count can help us to decide what kind of opportunistic infection we are looking at. If your patient CD4 is less than 200, but more than 100, so probably you are dealing with this group of opportunistic infection. But if let's say your patient CD4 is less than 100 but more than 50, then most likely you are dealing with OI that belongs to these four columns. Yeah, if your patient CD4 count is less than 50, then everything here are actually possible. Yeah, so you can make a good guess by looking at the exact CD4 count of your patient. And there's another way that you can actually predict what kind of opportunistic infection that your patient have is by looking at the site of involvement, right? So if you think that your patient have a central nervous system involvement, then this is the list of the opportunistic infection that you need to consider, and subsequently you perform investigation to prove it. Yeah. If you think your patient have an eye symptom, then this could be the likelihood of an opportunistic infection. If your patient presented with a lymph nodes enlargement in either cervical lymph nodes, inguinal lymph nodes, or intra-abdominal lymph nodes, then this could be the possible opportunistic infection or malignancy that you are dealing with. If for pulmonary involvement, GI or liver, usually they are quite similar. And it's for the skin, either it's fungal or Kaposi sarcoma or squamous cell carcinoma. All right. So after you have an idea by looking at the exact CD4 count and you're looking at the site of involvement, then it can guide you which kind of investigation you want to perform. Okay, because you can't perform everything under the sun, right? So investigation that we perform in HIV patients who come with cytopenia, not only to assist us clinician to come up with a diagnosis and treatment, it actually can help us to prognosticate our patients. Yeah, then sometimes at the investigation help us to look at complications. For example, if it's a HIV patient with a TB meningitis, then the brain imaging can tell us whether our patient has hydrocephalus or not. Then cryptococcal meningitis, LP, not only for the diagnosis, it also could help us to look into whether patient have developed this high CSF pressure. Then, of course, investigation also, we use it to monitor our patient's treatment response and also treatment side effect. So this is a list of different kind of investigations that we can order to investigate a HIV patient who come in with cytopenia, right? Of course, the lists are not that simple. There's a lot of investigations that we can do, but this is the common one, and this is those that we can order in Malaysia, right? So a blood test and a culture test for a specific organism, PCR test for TB, for CMV, viral load for CMV, serology test, and imaging include your X-ray, your CT, your MRI, your scope for biopsy when you're dealing with a TB gut, CMV gut. So just give you a rough example. If you suspect your patient have a CMV disease, this HIV patient have a CMV disease, then the test that you want to order perhaps could be blood for a CMV DNA PCR or even DNA viral load for CMV. If you suspect your patient has CMV meningitis, then of course you order CT brain or MRI brain. If you suspect your patient have CMV pneumonitis, then of course a chest X-ray in HRCT thorax or CECT thorax will be more appropriate. If you suspect your patient has CMV colitis, then of course refer to a surgical colleague or gastroenterologist to perform a colonoscope with a biopsy sampling is more appropriate. Yeah. So some patients, when they come in with pancytopenia and severely ill, then bone marrow can have a higher yield for us to get our diagnosis through a histopathological examination of your marrow or trephine, right? So sometimes when all these are a bit difficult in government setting, if you suspect CMV disease, the easier thing is we get our ophthalmologist colleague to help us to look into fundus. If there's presence of a CMV retinitis, then yes, we could start treatment and in a way that the patient do have a, if let's say you suspect your patient has CMV gut, for example, and your surgical colleague too busy to perform a scope for you, and then your ophthalmologist colleague can see a CMV retinitis, then in a way you can say this could be a true CMV colitis, okay? But of course, when you do not have CMV retinitis, it doesn't mean that your patient do not have CMV lungs or CMV gut, okay? So another example for this a whole set of tests that I show you if you want to investigate for TB or non-TB, non-tuberculous mycobacterial infection. So these are the tests that you might want to order and specifically looking into this organism. Okay. So all these are just example. And we can't order everything under the sun, and we must know that which is the site that we are suspecting, therefore which kind of investigation we are looking for. Okay, then if you are suspecting or lymphoma or leukemia, then a peripheral blood spill, a bone marrow examination is very helpful. Okay, yeah. So after we look into the group with a low CD4, how about the group with a normal CD4? Yeah, so the group with normal CD4, we treat them like a normal non-HIV patient. Yeah, if you how you approach a non-HIV patient with cytopenia, then this is how you approach this HIV patient with normal CD4 coming with cytopenia. This is because when their CD4 is more than 200, we are unlikely to deal with severe infection or opportunistic infection. And patients are usually quite well. You can treat them, investigate them outpatient, and you have more time for evaluation. Yeah, and we also can defer extensive investigation that like what I shown you just now, that you don't need to counsel for bone marrow and do LP, you know, usually they are not coming with severe infection and you have more time. So when you have this group of people who have cytopenia and you know that their CD4 is more than 200, then you further divide them into whether they are already on antiretrovirus therapy or not on antiretroviral therapy. Majority of the time, this group of people, their causes of cytopenia are medication related or malignancy related. So you have to go through their medication list, like what happened in the second case that I show you just now, Mr. Lim, eventually is a zero-wooding induced anemia. Then you just need to review their medication and change it, switch it to another regime, then it should be fine. Yeah. So if you go through the medication and you don't find any association, then perhaps you want to look out for a malignancy or hematological malignancy. Then you do like what you do for a non-HIV patient. Then for those HIV patients coming with a cytopenia and their CD4 is more than 200, or you believe that their CD4 is more than 200 and they are not on any antiretroviral therapy yet, then you go through the medication. Perhaps they are taking some traditional medicine or some supplements. And then after that, you look out for any evidence of malignancy. If you can't find it, then the next move is to quickly start antiretroviral therapy. And we know that 70 to 75% of the time, based on the paper that I showed you just now, we can actually reverse the condition. Okay, then after that, I move on to when do we transfuse HIV patient who come with cytopenia, right? So indication to transfuse, to top up the hemoglobin for this group of people is when they are symptomatic or they have a severe anemia or ongoing bleeding. Is like our general population without HIV. How about platelets? When do we transfuse them? So a different threshold of the platelet, it depends on the site of involvement. Basically, usually we don't transfuse a patient with platelet, whether HIV or non-HIV, unless they bleeding away, or either we are going for any invasive procedure, or patient have a very, very low platelet count, let's say less than 10,000, right? Otherwise, we wouldn't transfuse them with platelets. How about giving Neupogens to those HIV patients coming with neutropenia? There is no evidence, lack of beneficial data to support the use of Neupogen in this group of patients. But let's say your patient do have a Burkitt's lymphoma or the hematological malignancy associated with this HIV and post-chemo, then this Neupogen will be useful as per hematological malignancy indication. Yeah. So when we have a HIV-associated neutropenia and we believe their CD4 is less than 200 and they are not stable, they come with symptoms, then perhaps we have to initiate an empirical antibiotic, broad spectrum antibiotic for these patients. So I believe that most of you still very blur, or maybe I'm too fast. So if you cannot remember and you found it very difficult to remember and this topic are not interesting at all, then why not we prevent it from happening? Then we don't need to remember what is the causes of HIV associated cytopenia. Yeah, so we don't want HIV to continue, cases to continue rising, then without a HIV disease, then we wouldn't see all these HIV associated cytopenia, isn't it? Yeah, so by all method and all effort, if we can't prevent a single HIV disease from happening, then at least once a patient infected with HIV, we hope we can catch them early, we detect them before their CD4 drop to less than 200. Then we give them treatment, antiretroviral therapy. If after starting them with antiretroviral therapy, we want to retain them in our service, retain them in our treatment. Yeah, by all this effort, only we can prevent to see this HIV-associated cytopenia. So let me show you our statistic up to last year. If you look at for the past 10 years, our new cases of HIV is actually quite static, yeah, but we are not happy for that, yeah. We don't see a much reduction in number, right? So if let's say this number are continue to be static or even rising, then we are going to see more and more HIV-related cytopenia and HIV-related morbidity and mortality. Yeah, and even if you look at out of 100% of people living in HIV around us, only 50% of them, based on our 2020 statistic, only 50% of them are on ART. Yeah, so out of these 50% of them, only 85% of them have a viral load suppressed, meaning that we are still have a quite number of patients would come to see us with cytopenia, right? Okay, with that, I'll end my presentation.
So thank you very much, Dr. Ang, for that comprehensive, and it's a difficult task to do this, yeah? So let's look at the chat box, and I would like to see whether there is any questions from the floor. And I think a lot of comments saying that your presentation is clear and easily to follow and understood. So can you share with us, since there's no questions from the floor, can you share with us, the way that we, let's say, have you ever come across a patient who are stable on treatment and then they just had nothing, no symptoms at all, but present with, even though they are stable and present with pancytopenia? How would you want to approach this? They are already viral load suppressed, their CD4 is good, and they have been followed up for some time, but yet, at present moment, they just come with pancytopenia.
Yeah, so that based on my limited experience, we do see a very small number of some patients. Yes, they are already doing quite well with our antiretroviral therapy, and they have some form of cytopenia. But of course, we will investigate based on the algorithm that I showed you just now, that when a patient is on effective antiretrovirus therapy and the CD4 is good, then most likely we are not dealing with a severe infection or opportunistic infection. So we'll go through the medication and interaction list with the patients, then to screen the patient for any kind of possibility of malignancy. But a lot of time, eventually we couldn't find anything. And I found that when this group of patients, what happened is they tend to have a very, very low CD4 before they actually started antiretroviral therapy in the past. Meaning that before they were started with a heart therapy, perhaps that time their CD4 is like single digits and for few years. And I found that this group of patients actually, they tend to have a delay and slow kind of we call immune recovery, and then they tend to have this kind of phenomenon. I'm not sure if Dr. Chow, you agree with me.
Yeah, particularly if the total white you are talking about.
Yeah.
So I found out that the most important approach, or of course you rule out all the medicine and everything, but the most challenging part that we always encounter is when we do investigation, we will require a bone marrow aspiration. And that a challenge because the patients in the local settings, I think bone marrow aspiration and trophine biopsies are not very acceptable in certain group of, especially in our population. How do you approach this?
Okay, so yeah, bone marrow aspirations in this group of in Malaysia itself, like what you say, could be quite challenging. What I find is before we go through a patients and caretaker level, I find out that we clinicians ourselves are very afraid to perform bone marrow aspirations procedure. Yeah, a lot of time, who needs bone marrow? You know, who needs it? Definitely is this kind of cachectic patient, high spike fever patient, were very septic looking on inotropes, and all of them have low platelet, low total white. And a lot of time, these are the correct cohort of patients that need bone marrow, but yet clinicians are feeling so scared to actually puncture their, to get the bone marrow sample. So if we ourselves as clinicians, we are so afraid of getting sample and to get a diagnosis from bone marrow, how do we successfully counsel this group of patients or their caretaker to be agree with us? Yeah. So my good friends, hematologists, always tell me, actually for them, bone marrow is something like, not something that like, whoa, you operate your patients, you know, so difficult and you shouldn't do it, you know. Actually, this should be a simple procedure and very safe procedure in a skilled hand. Yeah, so the hematologists don't see the reason why we are so reluctant to counsel for bone marrow just because patient is septic, just because patient high fever and patient have low platelet and patient have low total white. And again, these are the group of patients who really need bone marrow. Yeah, so before we could actually convince the patients and the caretaker to be agree for this procedure, I think the first step is we ourselves have to agree that this, with a good hand, this is a simple and a safe procedure, and we can actually get the diagnosis and save our patient's life. Yeah. So as I find out that as long as we are confident and we will actually influence the patient and a caretaker to be agree with us. Okay. Yeah. And I find out that, yeah, I find out that HIV patients are slightly different from a non-HIV patient with cytopenia. I don't know. I feel that my patient, HIV patient, when they come in with this stage, a lot of time they are very easily counseled for bone marrow. Yeah.
Right. Yeah. So first of all, we have to be the one that actually offer and tell and counsel, saying that it is a need to know so that we don't hit blindly or empirically treating the case with multiple antimicrobials or anti-infectives. So there is a questions on the chat. How frequent would you do full blood count for those patients who are on probably on ART therapy?
Okay, so in patients that it really depends on their CD4 count and their general well-being. Yeah. So if patients that we just started antiretroviral therapy, basically we will see back patient within 2 to 4 weeks. Yeah. So within 2 to 4 weeks after we initiate the antiretroviral therapy, is to check their adherence and any side effect with therapy to make sure they continue to comply. So, but how frequent we perform this test is, it depends on what kind of antiretroviral therapy that we initiate. For example, our first line nowadays is Transfusion, which are associated with acute kidney injury. Then the priority will be reviewing their renal profile. But let's say for whatever reason, this patient cannot go for timely EM, and I need to give the patient Combivil, which contains zero wounding, then the next review within 2 to 4 weeks, then full blood count will be the one that I want to look into, look at the hemoglobin. Yeah, is case-to-case basis, very difficult to answer these questions generally. But if a patient already doing well with antiretroviral therapy, we do see our patient every 6 monthly. So we get them to be, we monitor them at least every 6 monthly. Yeah.
Is there another questions on the chat? Talking about secondary hemophagocytic or histiocytic lymphocytic hemophagocytic disease as the cause. Can you illustrate a little bit of this hemophagocytic as the cause of or contributing factors of your pancytopenia? Do you use clinical scores, H2 scores, or you wait until your bone marrow results? And then subsequently, steroid alone, dexamethasone is sufficient, or you follow the protocol for HLH with etoposide and things like that?
Okay, yeah. So HLH disease in HIV population is actually another entity. Yeah, even HLH in dengue is also another entity that we can't use a general protocol to apply on this group of patients. Yeah, so HLH disease in HIV patient, I would say almost all the time is associated with opportunistic infection. Yeah, if you can't find it, it doesn't mean patient don't have opportunistic infection. It's just our technology and our we can't find it. We can't find it. I would say almost all the time in HIV patient, when they have HLH, is associated with opportunistic infection, and we don't just have to treat the opportunistic infection, and the HLH will resolve itself. We don't use steroid in a HIV patient who present with HLH due to OI. Yeah, we don't. There are certain cases there's no guideline to guide us actually. There are some of the cases when we are really desperate, patient is dying in front of us, even starting a treatment for OI, but the immune hyper response are just keep on very the activation is too much, even you start treating the OI, but patient come too late, and I really need to control it. Then there are certain time we do give, but we won't give it for long, maybe a couple of few days. Then if patient respond, then we will stop it. Yeah, treating opportunistic infection will treat the HLH in HIV patients.
Yes, and most of the time we will actually ask our hematologist counterpart to actually assist us also as well. Yeah, so we come to a conclusion whether what regime we want to use also as well. Yeah, okay. So I think that's about it, the questions, and I think time is about time now. Let's thank Dr. Ang in the usual way, and I believe that this topic has actually opened the eyes of a lot of clinicians today, that pancytopenia or cytopenias in among HIV is a very, what to say, that not uncommon, and we all need to know how to approach whether it's a leukopenia or it's anemia or it's thrombocytopenia or bicytopenia or pancytopenia. There are lots of contributing factors, and not forgetting it could be infections, it could be malignancies, it could be drug interactions, and these are all step-by-step approach. And if you have trouble or in trouble, your friendly hematologist may actually give some input also as well. So not forgetting that some cases may need some hematologist input also as well. All right. And back to you, Norisha.
Thank you very much, Dr. Ang and Dr. Chow, for this really enlightening session today. I think we've all learned a lot. There are some questions in the Q&A chat box, Dr. Ang, if you can type in the answers. So I would like to say thanks once again to the contestants and participants of this day's session. Do join us next week where we will be discussing on heart selection and common interactions. Thank you very much.
Thank you.